All right. Since Joe's talking the most, I'm going to bring this back to him, and he can start.
Yeah, so when we talked about the spit, actually only one person in any of the groups had said that they have actually heard this before, at least in this framework. A couple of groups that said they actually used the kind of we discussed with the student, what are the serious, what are the probable. And so the one person who's heard this said that the interesting diagnosis they actually struggle with. Because again, what does that actually mean? How do you define an interesting diagnosis? So like I said to the groups, like I throw that in more is when you get some results back, when you get results back that you didn't expect at all. And then the treatable diagnosis, again, I use it more of a treatable as in a complaint. So again, if they're nauseous, making sure that people are not forgetting to give them the antiemetics. If they're describing the dehydrated patient, making sure that they're actually doing that treatable part, actually giving them fluid. So that's the framework that I've used. Well, like I said, and this is, again, I mentioned this to the groups, is pretty memorable for people when you tell them to spit early, spit often. That they remember that versus some of the other ones.
All right. But a lot of people had heard of the 1-minute preceptor or some variation of it, 3-minute or 5-minute preceptor, whatever it may be, but very few people had used it. A few of the things we talked about, so among those who had used it, they said it tends to be useful actually on busier shifts because it sort of, it allows you to provide feedback as you go, so you can have the med student present to you and give you their diagnosis, and then you can give feedback on the case right then and there. And so then you have that individual case feedback, and then at the end of the shift you can also do some additional sort of overall feedback. We talked about the fact that this, compared to other approaches, is more sort of teacher-directed. You are asking the student, but then you are also the one who is providing the pearls rather than trying to draw them out of the student. And then you give positive feedback and correct errors as you go as well. And then the one nice thing about this that seemed a little bit unique is that you force commitment from the student, and we talked a lot about that, how you sort of narrow in on a diagnosis and force the med student to commit to that, and then you can teach your pearls based on that.
Great.
Over here we were talking about teaching scripts, and we kind of compiled a list of teaching scripts. A lot of people were using this with some sort of like pre-canned talk that they could deliver to medical students without. So EKG was a popular one, how to read an EKG, tachycardias, different x-rays or clinical decision tools. And then we talked a little bit about like barriers to actually like delivering or using teaching scripts. And so somebody brought up teaching to groups with like a varied knowledge was something that could be problematic. Interruptions is something that I think is probably true for all of the different teaching strategies. And then like a lack of like a discrete diagnosis or chief complaint by patients, which almost never happens with patients that we see, was another one where people struggled to deliver a teaching script. But overall, a lot of people had some really good ideas for teaching scripts, and certainly some things that I wouldn't have thought of.
Yeah, I really like this idea. I mean, for our specialty, it's impossible to be an expert on everything. So you pick the things that you're good at, that you've lectured on, that you know about, and when a student happens to present a rattlesnake bite, you can dig in and really deliver that knowledge that you never get to deliver. So, great.
All right, and then lastly we have SNAPs, one that people I think were relatively unfamiliar with, not one I use a lot personally either. It's a tad bit longer. I think the first couple of things are things that we probably ask students to do, but analyzing the differential is something that students probably benefit from. This does seem to be a little bit more complex, and it might be better utilized for complex patients, or if you had a small group of students that you were teaching. It is interesting of having the students actually probe the preceptor with questions, which is really, I think, a great add-on as long as you have a student who's insightful as to where their confusion might be. And then selecting a case-based related issue for some self-directed learning really does come in handy sometimes when you're trying to get the student to be a bit more independent. So being able and empowering them sometimes to be able to go and find that information at that point in time can be particularly helpful.
So we actually I don't use this much like when I'm doing like clinical shifts with a student, but we have a direct observation with our student where the faculty goes in, and we found it more helpful for that because there's more time, and then the students know like going in what to expect, and then when they do their piece afterward, then they actually will email that to the faculty member who did their observation to kind of close the loop on that encounter.